Hello there, this is John, and this is the EMGM 106 iGel Lecture. So the iGel Airway device has been approved in the County of San Diego for use by paramedics at this time. It has not yet been approved for use by EMTs. So probably happen in the future. I'm just not too sure exactly when that's going to happen. The device itself is sized by weight. So you'll have to kind of guesstimate what the person's body weight is, convert that to kilograms, and fit them in wherever it might be, depending on one of the three sizes. Once you've picked one of the sizes, you're going to open the packaging, and what you're going to get out of this packaging is up in that upper right box on the screen. You have, of course, the iGel of the size you chose. You have an elastic strap to hold the device and to keep it into the patient in the proper position inside their anatomy, and you have some KY jelly to lubricate the device for insertion. On the bottom photograph, just a couple of points I want to talk about. The first one is the bite block area. That's that kind of like 2 or 3 inches on the upper portion of the device. And this has been reinforced. So if the person does begin to wake up a little bit and bites down on the tube, they're not going to bite through it. It's reinforced, which makes it rather stiff. And it's a great place for us to hold the device as we're inserting it because it doesn't flex at that point. If you go down to the bottom of the device, that green cup that you see there, the rim of that cup is very, very soft. It's like a silicone type product, and it literally conforms to the patient's anatomy. So once this is properly placed in someone's airway and it comes into contact with the area around the glottic opening, it starts to mold itself to that individual's airway anatomy. So it's a very effective seal. It seals and protects the trachea from secretions, blood, vomitus, things like that. And because it is so well sealed, as you're ventilating down this tube with your BVM, the air is going to go right down that tube, right through that cuff, and right into the trachea and thereby into the lungs. So it makes our ventilations much more effective as well. On top of all that, even though you can't really see it very well in the picture, there's a little protrusion at the bottom that fits into the esophagus. And so not only does this seal and protect the trachea, it also seals the esophagus from any vomitus coming up from the stomach. Lastly on this, if you look at the picture within a picture there, the big red arrow, it's pointing to the horizontal insertion line. So this is printed on the back side of the device. And when this is properly inserted and properly placed in the patient as needed, that black line should align with the patient's teeth. So the advantages of this device, the number one thing is you do not have to look where you're putting it. As long as you follow the instructions, it will slide in and go find its own place, and it will work great. Also, because of that, you don't have to put your fingers in this person's mouth. It's a lot safer for us as well. And like I mentioned earlier, because of that good tight seal around the glottic opening, it allows us to ventilate much more effectively. And because it seals that and also seals the esophagus, it protects their airway very, very well. Indications for use for the iGel. So this person's not breathing, the breathing's ineffective, they have some kind of altered mental status. The key point here is they cannot have a gag reflex. So pretty much if you have a person who's not breathing effectively, they're semi-conscious, they're unconscious, if they haven't got a gag reflex, more than likely you will probably insert an oral pharyngeal airway and ventilate with a bag valve mask. If they can accept one of the OPAs, they can accept one of the iGels. So contraindications are many. The number one we talked about already is they have to not have a gag reflex to insert one of these devices. The second one, infants and pediatrics, they're too small. They're below the minimum body weight, so we're not going to use them on those people. If this patient has either on purpose or by mistake ingested some type of base or acid product like Drano, pool acid, ammonia, bleach, those types of things, those chemicals really damage tissue and they cause a lot of erosion to the esophagus. So this iGel device does fit into the esophagus. It puts pressure on that tube, and the concern is if that tube, the esophagus, has already been compromised by the caustic substances, the pressure being applied by the iGel could rupture it, causing all kinds of horrible problems. The next one down is esophageal varices, and so this is seen primarily in patients who have liver disease. We have these blood vessels, they're called portal veins, and they run alongside and in or through our esophagus. And as the pressure inside the person's diseased liver increases, the pressure inside these veins increase, they get engorged with blood, they get very fragile, and they're easy to rupture. So again, as we're inserting this device in there, we're applying pressure to the esophagus. The concern is that these veins could rupture, causing massive hemorrhaging. The next one is if this person has a trach tube in place, they're being ventilated through a trach, or they have a stoma, then of course, obviously they're not candidates because you'll be ventilating through one of those two devices. The last and not least is this person might have some type of narcotic overdose going on. You can only imagine if you were to insert an iGel into a patient and then give them Narcan and they wake up, they would be really unhappy. So we're going to stick with just a nasal pharyngeal airway, bag valve mask, and of course the Narcan for those types of suspected overdoses. Equipment that we're going to need is going to have all three sizes in the airway bag. And remember, each size comes with a strap and KY jelly. You have a cervical collar to hold the head and neck in place after you intubate the patient. You'll have your suction unit, obviously. You have a BVM. You'll have an airway adjunct. And of course, you'll need some type of CO2 detector. And the one we use here in the county predominantly is called EasyCap, which we'll talk about here in just a couple of minutes. So how we prepare the patient for intubation? Well, first we want to hyperoxygenate this person. We want to get lots of oxygen on board. We want to supersaturate their tissues because we know that during the intubation process, there's going to be periods of apnea. So we want to prepare the body for that. So we're going to have our partner ventilate 100% pure oxygen once every 6 seconds or whatever's appropriate for this patient's situation. While they're ventilating the patient for you as best they can, you'll then check out your equipment. You'll pick the size iGel you need. You'll open up the packaging and you'll take out the iGel strap and you'll place the strap behind the patient's neck, just about at the level of where their mouth is. And that way it's there in preparation for once you do go to intubate. Once that's done, you're going to take the iGel that you chose. You're going to take it off. It comes on a kind of a plastic cradle to keep its shape. You're going to take it off of its cradle. You're going to squirt the KY on the plastic cradle, and then you're going to apply this water-based lubricant to the back, the sides, and the front of the iGel to give it pretty good lubrication so it gets in a little easier into the person's anatomy. At this point, you're ready to intubate. You're going to have either your partner do it or you can do it yourself. You want to put the person in a flexed sniffing position, so their head should be slightly flexed and their nose should be kind of pointing straight up to the ceiling. That's an ideal positioning for this person's intubation. So now you're all ready to go here. You're going to hold that iGel by the bite block. You can kind of sort of see it in the picture that I provided there. You're going to have your partner to do this. You can see in the picture that their partner has taken their thumb and forefinger. They've grasped the chin. They pulled it down to open the mouth. You can do this yourself as well. And then you're going to guide this device backwards and downwards. It's going to follow the roof of the mouth or the hard palate of the mouth. And it's going to follow that all the way down. And when you get almost all the way down, you're going to feel resistance. And you feel resistance, you're going to stop because you're in the right place. And you're also going to check and see if that horizontal insertion line is now somewhat aligned with the level of their teeth. At this point, you're going to take your strap and you're going to hook it onto the device to apply that downward tension to keep the seal and allow the device to mold to the person's anatomy. and then you'll probably have your partner ventilate for you, and then you'll be confirming the placement of the tube yourself. The manufacturer says there are situations where the person's anatomy might be different, and if you're inserting this device and you're getting about halfway down through the insertion and you're already feeling resistance, which is not normal, they're saying that it might be something because their anatomy is not totally normal. And so the cure for this apparently is to grasp the device and gently twist it side to side, back and forth, left to right, as you're advancing it into the airway, working it down, and then finally you'll feel that resistance and the black line will be aligned with the teeth and you'll be in. So once this is properly placed, the strap is on, your partner is ventilating for you 1 every 6 seconds or whatever is appropriate. You're going to take your stethoscope and you're going to listen for absence of abdominal sounds. This is the very first thing you should check. It's the easiest thing to listen for, and it literally takes 1 breath to find out whether you have sounds or not. And I'm sure, even though you're probably not going to admit it, but I'm sure many of you have had a cup of soda in front of you and a straw, and you blew into that straw and you heard that gurgling, bubbling sound caused by air going into a liquid. Same sound is what you're going to hear. If air is going into the stomach, it's going to cause the stomach contents to gurgle and to bubble. And so if air is going into the stomach, that means you're ventilating in the wrong place. You should then take out the iGel and then reinsert it and try it again. So what we're looking for is absence of abdominal sounds. So let's say at this point there's no abdominal sounds. I can move on to the second step, which I'm going to be listening to lung sounds bilaterally. Now, for the purpose of intubation, the best place to listen is going to be in the mid-axillary area. And this is for a couple of reasons. One, it's the thinnest skin right there, the thinnest amount of tissue. Even on grossly obese patients, it's very thin there. It makes for good sound transmission. And think about it this way, if you're on a call with a CPR in progress, there's patches on this guy's chest, someone's doing compressions on a sternum, and the anterior portion of the chest is pretty busy right now. So easiest place to listen here is the mid-axillary, 4th or 5th intercostal space. We're going to recheck our belly sounds and our lung sounds after every time we move the patient, from the floor to the backboard to the gurney to the ambulance to the hospital. Anytime we move this patient, we're going to recheck our belly sounds and recheck our lung sounds to making sure that this device has not dislodged for some reason. One last verification procedure, and this is checking for carbon dioxide. So because the lungs are really the only organ that excretes carbon dioxide, if we put this device on, this easy cap on, the larger, there's 2 sides to this. There's a smaller port and a larger port. The larger port fits onto the iGel, and the smaller port fits onto your BVM where your mask normally would be. As you're ventilating, air moves in and out, and as carbon dioxide comes out, it changes that color from purple, which is the way they come initially. It changes it from purple to any other of the colors you see on that range printed on the side of the device. So as long as we have some other color change, it's still a positive, quantitative way of saying that yes, we are getting carbon dioxide out of the lungs, so we are ventilating the right organ. You also notice that along with each color, there's a numeric value. And you obviously probably know that because colors can be very subjective and numbers can be objective, you need to report both the color and its associated value as well. So yellow and 5.0 or whatever it might be. So you've already secured the iGel with the strap. You can recheck and make sure that it's still holding tension and the device hasn't moved. At this point, the county says that if we move this person from where we found them, they want us to put a collar on them, whether they're medical or trauma patients. At this point, we're going to apply a collar onto the patient. and now we're ready to transport the patient to the hospital. So on the way to the hospital, you're going to be making a report to the radio nurse, and you're going to be providing information. One thing you're going to be providing is SD lead. So SD lead is size. What size iGel did you use? 3, 4, or 5. How far did you insert it? That's the depth. That's the first D. That would be to the insertion line at the teeth or gums if they don't have any teeth. Lung sounds, were they present or were they absent? Hopefully for us, they're present. And title, we want to provide the color of the EC cap as well as the numeric value. And we want to provide the abdominal sounds. Were they present or were they absent? Of course, they should be absent. And the last D in this is just to remind us that we need to provide documentation both during our radio report and with our patient care report as well once we get to the hospital. So once you have an advanced airway in place, let's say you arrived at a scene and there was a person in cardiac arrest, you started compressions and ventilations, you inserted an OPA, you bag valve mask ventilations are continuing, but you decide to move on to an advanced airway like you see here in this photograph. Once you have an advanced airway in place, because the airway is so effective and efficient at delivering ventilations, we no longer go by a ratio. We don't do the 10-to-1 ratio at this point now. Now the compressor just compresses at about 110 compressions per minute. And the person ventilating, they're just going to ventilate 1 every 6 seconds. And they can ventilate right through those compressions. There's no need to pause or stop for each ventilation. So ventilations are now once every 6 seconds, and they're asynchronous to the continuous compressions. So like I mentioned before, always reconfirm your tube. Every time you move the patient, there's a change in the patient's status. They're becoming more cyanotic. It's becoming more difficult to ventilate the patient, whatever it might be. Check as often as you need to. You should recheck just prior to getting out of the ambulance. You should recheck as well. And the county says you need to have at least 2 complete SD lead assessments documented on your PCR, whether you transported the patient to the hospital or whether they were pronounced at scene and left for the coroner's office. Lastly on all this is this device is a great device to use on trauma patients, especially if the trauma patients are entrapped in vehicles or other types of entrapment. Imagine if someone's trapped in a car, they're sitting up, they're unconscious, they're not breathing. You can't get to them just yet because rescue hasn't gotten there yet to cut them out of the car. You could reach through the window, insert one of these devices, secure it, and ventilate this person while you're waiting for rescue to show up. It's a great device for this. So this person would have a collar in place. So if the patient already has a cervical collar in place, maybe the first responders applied it before you arrived. Maybe halfway through the call, you decide this person needs an advanced airway. So what you're going to do is you're going to have someone hold the head and neck in place using manual inline stabilization. You're going to open the face of the collar. You're going to release the front of the collar. This allows you to pull the jaw down to open the mouth. You're going to intubate. You're going to verify. You're going to secure, go through all the steps, and you're going to resecure the collar, and then you're back in business. Very rarely it does happen, but sometimes we do need to extubate advanced airways. Usually it's because patients start to wake up and they start fighting the tube. They wake up, they're very frightened. They try to grab it and pull it out of their mouth and things like that. If this person starts to become more aware and they're fighting the tube, you can extubate, but it's by a base hospital order only. You have to get permission from the radio nurse from the base hospital. If, on the other hand, if the airway just fails for a mechanical reason, now these iGels are super bulletproof, and I can't imagine any of them failing unless they were improperly inserted. But if this airway starts to fail for some reason, you can remove it on standing order, and you can replace it on standing order as well here in the County of San Diego. And I think we're done.